Doctor.
Okay. So next topic is we're going to talk about presenter mode. Heart failure. Then we'll talk about the PE. So I'm just going to talk about, again, heart failure. We're going to talk about the burden of disease. We're going to talk about definitions. We're going to talk about the pathophysiology, talk about diagnostic therapeutic approach to heart failure, and we're going to talk about the evidence-based algorithm for treating acute exacerbations of heart failure. So, heart failure is quite common. Again, it's just like we talked about asthma in the beginning. I think you should understand heart failure as a syndrome rather than a single disease. It's a syndrome with definite pathology, and feedback mechanisms to compensate for it. But the problem can be due to multiple different regions of the body. So it's defined as a pathophysiological state which the heart is unable to meet the oxygen requirements or tissue requirements of perfusion. And to do that, the heart has to increase the pressures to try to facilitate the filling, to the blood flow. So the American Heart Association describes it as a structural, functional cardiac disorder that impairs the ability for ventricles to fill or eject the blood. The burden disease. So heart failure is quite prevalent. And we see it in increasing as people's age. With patients above 75, around 10% of them diagnosed with some degree of heart failure. As men are more predisposed to it, it's one of the most common reasons for admissions, actually, especially in the elderly, with significant morbidity and mortality. If you're diagnosed with acute heart failure at one point in your life, you have a 5-year mortality rate of 50%. So 50% of people with diagnosis of heart failure will be dead in 5 years. So it's quite significant. There's very high burden of cost of hospitalization, medication, obviously days of lost work and functional disability. It's important to understand the NYHA classification because it's a very gross classification of symptomatology of heart failures. How symptomatic are you at baseline and how impaired are you for function? It's a very readily used tool to describe the severity of the disease. So like I said, pathophysiologically, it's complex. It's dysfunction of the heart or any component of the cardiopulmonary system with feedback mechanisms to try to compensate for this dysfunction. The feedback system through the renal system, through the vascular system, through the neurological system. So it's quite complex in that sense. And a lot of what we do in medicine is try to mitigate these feedback loops to optimize the patients, improve their survival. So I'm going to give you an example of how heart failure works. So let's talk about common causes of life. Let's say you have a heart attack, you have acute coronary syndrome, and then you have worsening of your cardiac function. So you can't eject blood as effectively. So what happens? Assuming you don't die from that acute event, assume it's a major, the function doesn't completely go back to normal. You can't eject blood as effectively. So what does your heart do? It starts getting thicker to compensate for that. So it can fill with more blood and eject more effectively. But the thicker part needs more oxygen. And then your organs end up not seeing enough perfusion. What do? They increase they start shunting blood. So the vascular endothelium becomes stiffer, and you develop hypertension as a compensatory mechanism to improve perfusion. And over long periods of time, that will end up with renal failure, which is cardiorenal syndrome. Another way which we end up with heart failure, let's talk about it. Let's say you have chronic pulmonary disease, and COPD being common, you have chronic hypoxia. Chronic hypoxia causes pulmonary hypertension. It causes the pulmonary vasculature to become very stiff and increases the pressure. So eventually that pressure, the right heart will see that pressure and then will start to fail over time because it's pushing against a lot of pressure, becomes thicker and doesn't eject as well. And then the blood pressure starts increasing, into the anterior side. So your left heart starts to pump against more pressure as well. And eventually, the left heart starts to fail due to the high blood pressure. So that's what's called corporal banality, from right heart failure causing eventually left heart failure. Let's say you have pheochromocytoma, hyperthyroidism, you have an endocrine disruption, and you're constantly tachycardic and hypertensive from the abnormal, your release of these endocrine hormones. So the constant tachycardia is going to make your heart develop a cardiomyopathy, worse than ejection fraction, etc. Let's say you have chronic anemia. You don't have enough oxygen carrying capacity. So does your heart do? So it becomes tachycardic to compensate. So eventually the tachycardia will end up with worsening ejection fraction and cardiomyopathy. So the point is to say, same thing with an arrhythmia, that these structures are all interconnected. And most of our treatment is based on mitigating the harm from the compensatory mechanisms. Does that make sense?
Yes.
Okay. So understanding heart failure, you need to understand the basic function of the heart. So the heart's basic most important function is to eject blood. It seems simple, but it's actually quite more complex than that. But it's important to just understand the components of ejecting blood, also known as the cardiac output, which is the amount of blood ejected over a period of time, which is the stroke volume, which is the single ejection, and the heart rate. The heart rate is affected by many things, such as the neurological system, the catecholamines, etc. And obviously the electrophysiology of the heart itself. So if you have an arrhythmia, like a heart block or a supraventricular tachycardia, or if you have pheochromocytoma or hyperthyroidism, all these things can cause abnormal heart rates. And then if you have an abnormality of your stroke volume, that again can happen through multiple things, through abnormal filling, through abnormal filling time, through abnormal ejection, abnormal filling, like I said, like right-sided heart failure, renal insufficiency with fluid retention, abnormal like ejection, like if you have stenosis of your valves or regurgitation of your valves, this will all cause abnormal ejection, or you have severe arterial hypertension that causes significant afterload, so that makes it difficult to push blood against the vessels, so you have to increase your pressure. So it's complex, but essentially the function is the same, but any part of it can become abnormal and can cause heart failure. So what are the most common causes of heart failure? The most common cause across the populations around the world is coronary disease. It's not necessarily like a big heart attack, but microvascular disease, small vessels in the coronaries. That's usually due to atherosclerosis, right? Poorly controlled diabetes, hypertension, smoking, all these things cause atherosclerotic changes and cause small infarctions in the heart. And sometimes they're large ones, large ones like an end STEMI, or even larger one like a STEMI. So chronically over time, it causes heart failure. It's the most common cause. And then eventually there's restructuring of the myocytes themselves, and they become fibrotic, and you develop ischemic cardiomyopathy with non-functional myocytes. The second most common cause is myocarditis, cardiomyopathy. From some of them which is idiopathic myocarditis. We don't know why people get it. They get dilated cardiomyopathy. There are some genetic factors related to it. You can get it from medication or substance induced from alcohol or from stimulants. And there's some diseases that can also cause it, and some infectious agents. Valvular heart disease is quite common. So again, and you still see a significant amount of rheumatic heart disease, from infectious autoimmune response to group B streptococcus. And then we see pericardial disease is less common. The pulmonary diseases is also another cause, like we talked about, corporal banality and chronic COPD. So how does the heart compensate for it? If it's safe, well, it tries to increase its, like I said, stroke volume, tries to increase the amount of blood it pushes out. The body tries to increase systemic vascular resistance, and then eventually this all leads to cardiac hypertrophy. How do we classify heart failure? And this is important. You can classify it based on how we talk: forward versus backward, acute versus chronic, right versus left. But mostly now the nomenclature is heart failure, preserved ejection fraction, and reduced ejection fraction, using the ejection fraction as the way to dichotomize the type of heart failure. So that's what you'll see in medical charts. So it's important to note we read a medical chart, if the patient has heart failure, what kind of heart failure he has, because the response to treatment and the causes are quite different. So in the emergency department, sometimes we do diagnose acute heart failure, but mostly what we're doing is exacerbation of disease. So that's across the part of most things. Just like, headaches, we see exacerbation of headaches, asthma, we see exacerbation of asthma. Same thing with heart failure. So yeah, exacerbations of heart failure. So what exacerbates disease? Well, exacerbates disease is what causes it in the first place. That's always what you should think about. But specifically for heart failure, it's a chronic disease. So they're on medications that prevent it from progressing and keep it controlled. So the number one cause is non-compliance with medications or fluid restriction, which is a big part of treatment of heart failure. So if they're non-compliant, they drink too much fluids, or they don't take their antihypertensive medication or antiarrhythmia medications, they'll get their heart failure will exacerbate. And then the other causes that initially cause it, like ischemia, is a common cause of exacerbation, acute heart failure. Just like it causes it chronically, it can acutely worsen it. And then any systemic infection, any stress on the heart, because these hearts don't function well, they're already in a compensated state. So if they need to work harder, they can't do that. If I asked you to run, up and down the stairs, if you're healthy, you can probably do that. But if you have heart failure, you probably have an exacerbation of your heart disease. You won't be able to do that. You can't handle that stress. So think of it that way. So if they have anything that makes their heart perform a marathon, such as infection, or anemia, or pregnancy, or ingestion of a toxin or a stimulant, then that will cause to exacerbate the disease. So think about what's stressing the heart now to cause it to exacerbate. So those are the common reasons for acute exacerbations. So how do you approach someone with heart failure where you need to understand why they have heart failure? I think that's an important one. You need to ask about ischemic symptoms and heart failure symptoms. You need to ask them about previous instrumentations or diagnostic tests done for their heart failure. Are they on medications? Have they had echoes? Have they had echographies? And you need to ask about, if this exacerbation is what's precipitating it, infectious symptoms, ischemic symptoms, non-compliance history, etc. On the physical exam, obviously, again, when you're examining, always count about how the patient looks. Do they look sick or they look well? Because heart failure patients come in two types. They either are severely decompensated and cardiogenic shock, or compensated, which is the more common one. If they look ill and hyperperfused, it's very serious, or they can be well perfused, and that's a more common thing. Often we'll find crackles or wheeze or abdominal lung sounds. Like, remember, we talked about wheezing in the asthma talk. JVP is still taught under internal medicine cardiology. It's not really a very good tool. It's not specific or sensitive. Like you might say the JVP is high. I might disagree, but it still is a tool to use for increased filling. Part of the examination of heart failure patients is obviously a cardiovascular exam, including lung sound. And heart sounds. Why do we care about the heart sounds? Not because I want you to hear splitting of a heart sound or an attenuated sound. It's not really. That's more of things you study in medical books than it's on exams. More so for acute valvular disease, because that's a very serious complication of acute heart failure. If you have severe aortic stenosis or acute mitral regurgitation, that's a very concerning finding. Both of those things can cause significant mortality in patients. So mostly you'll see in the emergency part now, we diagnose heart failure with ultrasonography because it allows visual, look at the heart itself. Comment about the function, the valves, etc. Adjunct testing is often indicated. Most of these patients will need testing. Look at what's exacerbating the disease. So they will need CBC renal profile. They will need cardiac biomarkers. They'll need ECGs. They'll need X-rays. Mostly not. Chest X-rays are useful because they look for precipitants such as infections, and they look for disease itself, which is pulmonary edema, which is demonstration of exacerbation of heart failure. They look for chronic disease such as LV, hypertrophy, pleural effusions. All these things suggest they have chronic heart disease. CBCs are useful, like we talked about, anemia, etc. Basic metabolic function, because it could be that they have pulmonary edema not from heart failure, it could be from renal failure. Cardiac biomarkers, essentially troponins, whichever type of troponin, look for acute ischemia. BNP is quite useful to test, measures the stretching of the left atrium, and usually changes the BNP suggests that there's acute exacerbation of the disease itself. If it's very severe disease and they have end-stage heart failure, the BNP is going to be always too high to detect, so it's not useful in some patients. And if it's negative, it's almost essentially rules out heart failure as a cause for the patient's symptoms. ECGs, again, are very important in these patients for ischemia and for arrhythmias that we talked about, for conduction problems. Is it bradycardia, tachycardia? All these things are important. How do we treat heart failure? Well, you need to understand what's the underlying cause. Somebody with aortic stenosis and heart failure is not going to get better because you gave them some Lasix. It's unlikely. It's a mechanical problem. Somebody with ischemia, you need to fix the ischemia, right? You need to revascularize that patient. Someone who's anemic and heart failure or has an infection, you need to fix that cause. So we have to understand what's the cause. We have to understand what's precipitant, and then we have to try to prevent it from getting worse, basically, until you fix the underlying problem. They come in two flavors: perfused and hyperperfused. The majority of them are going to be the well-perfused heart failure patients with increased pulmonary edema. Those patients can be hypoxic and they have increased work of breathing. So if they're hypoxic, give them some oxygen, because obviously, as they're so hypoxic and so dyspneic, you need to put them on a breathing machine because they can't breathe anymore. They're not perfusing their organs anymore, but that's less likely. Usually, sitting them upright is helpful. Most of these patients are hypertensive because part of the compensation is their afterload is quite high, and that will worsen the heart failure. So by decreasing their blood pressure, you actually improve their symptoms and improve their mortality. So we do that with nitroglycerin or afterload lowering agents. There used to be evidence for morphine, but we don't really use morphine anymore. There's in fact increased evidence of harm in heart failure with morphine, so we don't use it. Diuretics are key. A lot of them are volume overloaded, and even if they're not volume, it helps with the venous filling and the venous pressures. The diuretics, Lasix, shabaha. There's different types of diuretics, but mostly we use the Lasix or furosemide. So usually we just treat the underlying cause, acutely treat the symptoms, and they will get better. With improved oxygenation and work of breathing, and go back to their baseline, whatever it is, depending on how their severity. Now, the second type is hypoperfusing heart failure patients. Now, these are usually very sick patients. They're in cardiogenic shock. The heart failure is causing itself acute organ dysfunction because there's not enough blood going to the organs. So these patients are usually hypotensive. They might be confused or even peri-arrest or even arrest patients. Because that's essentially how people die from heart attacks due to hyperperfusion from VTAC or cardiogenic shock. So a lot of times you need to give them some fluids to help get the cardiac output up, as opposed to diuretics. And then they often will need medications to try to maintain the blood pressure and the cardiac output. So you need to put them on inotropes. And a lot of them have an underlying mechanical cause, so they need to be fixed to be mechanically. They need a revascularization with a cath lab, or they need to see a cardiac surgeon to fix the valve issue that they're having. So these patients often don't do well, end up with multiple organ failure and death. So it's important to understand that heart failure is a complex syndrome with neurohormonal changes that are compensatory, that are detrimental over time. So the medications we use chronically are used to treat these detrimental responses to the heart failure itself. It's important to understand the precipitating cause because you need to treat that. That's the only way the patient's going to get better. Most patients with heart failure just need to be reinitiated on their medications, and put up in a sitting position, decreasing their blood pressure if they're hypertensive, and given diuretics. If they're in hyperperfusion or shock and cardiac shock and heart failure, then these patients need medication to support their cardiac output, like high-risk medication. They often need surgical intervention to fix the underlying problem. That's it. Any questions about the heart failure talk?
All clear, doctor.
Clear, doctor.
Thank you, doctor.
No more. So last topic today we're going to talk about is PE. I know you studied PE. أخذت أنتوا chest pain محاضرة صح؟